Greetings everyone. Welcome to today's talk to all our listeners. So the topic for today is we're going to briefly discuss introduction to navigation, especially for postgraduate trainees and residents. And also we'll discuss the evolution of navigation technology over the years since its inception. So what is navigation? Navigation is a computer assisted surgical technology. It basically uses intraoperative or preoperative images of a patient and intraoperatively helps the surgeon by guiding him with regards to virtual imaging inside the OR, and he can superimpose his implant positioning, the instrument positioning, or any handheld instrument that he is using, and he can get trajectories of the positioning vis-a-vis the patient's spinal anatomy. So it is practically giving you a third eye, which helps you see what is not seen on the intraoperative table when the patient is on your table, and helps you guide implant positions or implant placement accurately. So the need of navigation probably arose with the advent of the segmental fixation techniques. With the pedicle screw development, you have an option of having a multi-column purchase and segmental fixation. These pedicle screws help us fix or address pathologies all the way from the cervical spine to the sacroiliac joint. And with the use of these pedicle screws, somewhere it became relevant as to how optimally they are placed to get the best biomechanical hold from these screws. Optimal placement and accurate placement was the need of the hour, and navigation was as a result born, where you would use navigation technology to get optimal screw positioning. The origin of navigation for spine surgery probably has its roots in stereotactic brain surgery. So for brain surgery, there was the opportunity of having deep-seated cranial lesions which needed stereotactic surgery. So the reference frame could be attached to the skull. And since there was no movement between the brain and the skull, it was possible to pinpoint, stereotactically assess and treat lesions in the brain in different regions of the brain. However, with spine, there was a slight change. As opposed to movement between the brain and the skull, it's fixed. But in spine, unfortunately, because there are multiple mobile segments, we have to adjust the navigation technology to this part of the spine where there is additional mobility. So for spine, due to the mobility, navigation has needed to be more complex. The utility of navigation has been due to the improvement in malposition rates. So if you look at freehand pedicle screw placement, there have been malposition rates which have been quoted as high as 50% in the thoracic spine. This accuracy can be very much improved with the use of navigation. And with the use of navigation, in fact, in thoracic spine, the accuracy rate has been improved where only 5% malposition has been seen. Obviously, for more complex regions such as cervico, craniovertebral junctions, or for the cervical spine, this added accuracy helps us use pedicle screw fixation systems even in cervical spine. And there is an added advantage with the complex regional anatomy. So what is the basic setup for navigation? So we will use the OARM as our reference navigation system because Sancheti Hospital has an OARM. We'll be going through some of those basic setup requirements for navigation and in this introductory lecture. So if you look at the OARM, it is a portable intraoperative navigation system. It is able to be moved in and out of OR. Once it's inside the OR, it can circle around the patient who is lying on a special table, and it goes through a 360-degree spin where a scan is performed. Once this scan is performed, these images are then able to be transferred onto a computer screen where you have the added advantage of virtually accessing the entire anatomy and placing your implants. At the end of the procedure, you can have a second spin of the arm to confirm the accuracy of your implant position. And once this is done, the O-arm again moves out of the OR to allow space. So this is how it works in the OR. So for this, basically, there are a few setup requirements that have to be met. So you have to have an optical camera which is able to pick up the light emitting diode or the gluons which are placed on the reference array and all your instruments. You obviously have a virtual screen which helps you see how is the trajectory of the screws and the implants that are being placed. So in short, this is a working model of what you see, and you have a minimal invasive reference array or something that is placed on a bony landmark on the patient's body, for example, a spinous process. You have a handheld instrument which again has light emitting diode or gluons which are able to calibrate the trajectory of your implants or the trajectory of your instruments vis-a-vis the patient position in the OR or in the operating theater. And on the screen, what you get is a virtual display of how the implants are being placed and what is the trajectory of the screw that is being put. So once the steps of the setup include that once the patient is positioned and under anesthesia, the first thing we do is to attach the minimal reference array or the MIRA onto a bony landmark. The important point at this time is to make sure that your MIRA is well fixed and there is no mobility between the MIRA and the patient's body, because this will lead to loss of accuracy and fidelity. So there should not be any movement between the reference array and the patient's body. Then you bring in the O-arm to scan, but you have to set the limits of the scan. So suppose you are working on a lumbar spine where your prime area of concern is say between L1 to L5. So your limits of the scan are set up so that the machine is able to scan the patient's body, say from D12 up to sacrum. Similarly, if you are operating on say a pathology at D6, D7, then you might want to set your volume of scan so that you can scan anywhere from T3 or T4 or thoracic 4 vertebra to all the way to thoracic 10 vertebra. Once your field of view or the volume of the scan has been set, then what we need is apnea. So all the patients who are undergoing the scan temporarily for a few seconds while the scan is going on, we limit the patient's breathing because the apnea is required, because any breathing movement can bring about additional chance of error or loss of accuracy. So we induce a apnea in the patient for the patient in the OR, and then the scan is conducted. Once the scan is completed, that's generally lasting between 5 to 30 seconds. Then again, the Boyle's machine is switched on and breaths have been started. So this constitutes the O-arm spin. Once the O-arm has gone through the process of the scan, the image acquisition is undertaken and you get reformatted CT-like images on your visual screen, which represent the patient's true anatomy. You then have to register and calibrate your instruments. So all your handheld instruments such as pedicle probes, Lenke or the pedicle owls, drills, taps, electronic power or power instruments such as burrs, they all have their verification and calibration done so that they can be synced and their position live intraop virtually can be seen by the operating surgeon as these instruments are introduced into different parts of the spine anatomy of the patient. All the instruments that we use have these light emitting diodes so that their position vis-a-vis the patient position can be ascertained and image quality and image accuracy is maintained. So for example, you have images like this where all your handheld devices, whether they are probes, owls or burrs and drills, have those light emitting diodes. Something similar to this. Another important concern during the surgery is that the optical camera should have uninterrupted or unrestricted access or viewing towards the MIRA and the handheld instruments so that the light emitting diodes can accurately assess where these instruments lie in three-dimensional space when it's concerning the human anatomy that is being operated upon. Also, when you have good uninterrupted visual access between the optical camera and the light emitting diodes, you get good screens, accurate images intraoperatively with real-time change in the trajectory. As you move your hands, the trajectory of the planned screw can be simultaneously seen on the screen in front of you. So what are the steps in navigation? So I think there are 5 basic steps. The first step is image acquisition. Then you have the surgical planning or the intraoperative planning of how the surgery is done. You have a registration of this in the OR where the patient anatomy is registered to your navigation system. Then the computer algorithm is used to generate accurate virtual images, and then they guide the implant placement. Now, based on the image acquisition and the registration with in the patient, I think the evolution of navigation can be traced all the way from the first generation navigation, in which preoperative CT was done. And this preoperative CT used to be fed into a system, and the preoperative CT would guide the implant usage at that time. Then you had second generation where image acquisition was not through a preoperative CT, but was a fluoro based. And then again in second generation, you have 2, where you can have a 2-dimensional or a 3-dimensional system. And third generation is the intraoperative CT based generation, which we are currently using, which is the most, the latest, where you have intraoperative CT scanners to perform the image acquisition. Over a period of time from first generation to second generation and third generation, the registration process has gone from manual matching to automated registration. So registration was in first generation manual, and then over second and third generation, it has become automated. And thus, with these changes in image acquisition and registration process, the generations of evolution have taken place, and now we are currently in a third generation navigation system. So navigation was probably first introduced simultaneously by Merlot, and it was in the States that this was done, and France also. So if you can see, this was done with preoperative CT. So the patient used to have a preoperative CT done. Those CT images were then fed into the computer system. You can really see that this was vastly different from current technology, because the graphics workstation was a 64 megabyte random access memory. So nowadays we see computer systems which are ranging anywhere from minimum 500 to a gigabyte, and the hard drive there was 1 GB was the hard drive's capacity, and we now have hard drives which have in terabytes capacity. The image acquisition was pre-op CT. So once you had the preoperative CT of the patient, you would feed it into the computer. Then you would go and expose your posterior elements, fix your referencing system onto the spine, and then manually match, because there was no way of otherwise superimposing the preoperative CT, which was done in the CT machine in a supine position, to intraoperative position where the patient is now prone. So you had to physically match the bony landmarks that you see with the preoperative CT, and this was manually done. So this matching required between 8 to 12 points, and sometimes with complex anatomy, it's quite difficult because surface landmarks can get obliterated. Additionally, you need to match extensively 8 to 12 points. So there was no scope of having a minimal invasive surgery, and you had to formally expose a large amount of the posterior bony anatomy to be able to match them. Obviously, without matching, you could not extrapolate the images, because the CT which was done preoperatively was in a supine position, and the surgical position where the patient is operated upon is in prone. And with any mobility inside the theater, quite often registration had to be repeated and matching had to be repeated. On the screen, you can see there was no, all instruments had wires which need to be connected to the computer, and you didn't have the option of a significant optical camera where you could read the light emitting diodes signals from optical camera far away. So in summation, the first generation, the image acquisition was pre-op CT and registration was manual. So that's how it was. So this was a rough workflow. So you did a pre-operative CT. That was the first image here. Then you would plan your screws. So suppose you want to, this is the T12 vertebra, and you want to plan a pedicle screw on the left side. Then once this plan was fed into the computer, you would have to match 8 points on the T12 vertebra that you see on the preoperative CT, so that the patient's position in the OR can be integrated with the computer algorithm or the preoperative CT. Once this was done, you could then proceed and check accuracy, and if it was verified, the accuracy was verified, the navigation technology could be used to instrument the pedicle of T12. But if suppose you had loss of fidelity, where there was some movement and the loss of fidelity occurred, then you would have to re-register and verify and match at every level. So for say one screw you need to match, or say one vertebra you would need to match 12 points, and then you would have to repeat the process for every subsequent vertebra. So one of the major drawbacks of the first generation navigation system was the time it took in terms of adding OR time in terms of conducting the surgery. The second generation was a fluoroscopy based navigation system. The advantage of the fluoroscopy based navigation system was it was a biplanar imaging as opposed to a preoperative CT. So the image acquisition was inside the OR with the fluoroscopy machine, and registration improved, becoming automatic, where physical matching was no longer required. So the final output was you would get virtual fluoroscopy images like you see in current day Shyams, but the drawback was that it was two-dimensional. So although the image acquisition was intraoperative, number one, it was fluoroscopy based, number two, and registration was automatic, the quality of imaging was that of an O-arm, was of like that of a C-arm. So somewhat like this. But the drawbacks what you would get is only AP and lateral projections. You wouldn't get axial views. Second is the field of view was quite small. So you could probably see an instrument under navigation, say a segment or maximum two segments. So between L2, 3, so 4 screws, or maybe between L2, 3 and L3, 4, so maybe about 6 screws. So the field of view was very limited to 2 to 3 segments. The reference frame was in the middle of the image that you had to maneuver and use it. The image quality was that of a C-arm. It was difficult to do surgery for spine deformity, especially when you had multi-level pathology, not just limited to 2 to 3 segments. Obviously, radiation exposure was considerable because you would have to repeat this for if suppose you have 4 or 5 level fixation, then the navigation would have to be repeated, and you would have to do it for each and every segment that was separately to be addressed. Additionally, because the image quality was that of a C-arm, it was difficult to use this technology, especially in complex regions like cervicothoracic junction, which not clearly seen on the C-arm. And also in obese patients where due to the obesity, you wouldn't get good quality images. So these were the examples of the images. So you would get a virtual screw, the trajectory could be seen on the screen, but at the end of the day, the image that you would see would be that of a fluoroscopy machine and not truly a CT-like image, and it would be like a radiograph that you would see. And you could use the instruments to place your implants and see trajectories in your spine pedicles, but you wouldn't get the axial view. You would get just the AP X-ray and the lateral X-ray to maneuver your instruments with. So those were the drawbacks of the second generation. Second generation fluoroscopy based navigation improved when it went from 2-dimensional to 3-dimensional. So the 3-dimensional technology added another perspective to use in the OR. So this came with the use of the cone beam CT technology, which was a big improvement. So what happened was you would use a regular X-ray machine like a C-arm machine, but it would move through a semicircle where it would shoot all through 180 degrees, and as a result they could reformat those images to bring you CT-like images. The advantage being you would get the axial sections now. So it was not only the AP and lateral or the coronal and the sagittal planes that you would see, but you would get additional axial plane imaging. The image acquisition was again like previous second generation fluoroscopy based. It was intraop. Registration was automatic, so you didn't have to physically match 8 to 10 points because since the scan was done inside the OR, there was no change. So patient was in prone during scan, and you're operating again during scan. So a prone position. So navigation needed not have automatic registration was fine. And you would get axial images. So it gave a 3-dimensional image technology. Additionally, the images were slightly more CT-like, so it was better than 2D fluoroscopy-based navigation. But again, some problems persisted because it was fluoroscopy-based. Again, for obese patients, it was not great. Image quality would suffer. Regionally complex regions such as cervicothoracic junction or the craniovertebral junction, you wouldn't get good quality images. So those were some of the drawbacks. So if you want to see what is cone beam CT technology, it's basically as like you have your CT scanner, which is basically X-rays being shot all through from 0 to 360 degrees and reformatting of the images. The same CT beam, cone beam technology is used by the fluoroscopy machine to give you CT-like images in the OR, and thus using the fluoroscope, you are able to get navigation on images that appear like CT scans. So this is, for example, example of a ISO-C navigation system. So you can see that the image quality, if you see, is like that of a CT, but not really a very good quality CT. But yes, you can see axial, you can see sagittal, and you can help plan a lateral mass or a pedicle screw in the cervical spine. Now, with the advantage of automatic registration and with the advantage of the cone beam CT technology, minimal access surgery was possible. So you have to just open a small part of the spinous process and attach your mira, like you can see on this screen here. And once this mira was attached, you could then scan it. But the drawbacks again was the scan volume was small because you could do maybe 4 or 5 levels. And as a result, if you have to say instrument a longer portion of the spine, say from T4 to L4, then you would have had to repeat the scan for every 4 or 5 levels, so that 2 or 3 scans put together would be able to help you navigate the entire instrumented region from T4 to L4. This Shyam would move again through 180 degrees and then give you reformatted images. And occasionally, if you had a long segment fixation, you would need to do multiple scans. Then comes the third generation CT scan, third generation navigation. So this is what we currently use at Sancheti. This is the OARM. So the OARM is a cone beam CT technology. It's an intraoperative scanner. So image acquisition is intraoperative, registration is automatic. The OARM spins through 360 degrees. So what image quality you get is more akin to conventional multi-detectors, CT slices. So the quality of the image is really good. It looks like a really, like a good quality CT scan. The field of view is more. So apart from just having 4 or 5 levels, you can sometimes instrument up to 6 to 10 levels based on the volume of scans. So there is something called as stacking, which is available in the OARM, where you can stack 2 6-segment scans and then be able to see up to even 12 segments of the spine at one go. All the instrumentation that you use for spine, such as your drills, spurs, owls, sounds, they can all be integrated with the OARM technology, and they have special light emitting diodes or gluons which can be attached to the handle at each of these instruments, and thus you get real-time feedback on using all power instruments and handheld instruments while you're doing the surgery. The OARM integrates well with S8 stealth navigation, which helps you take this technology for especially minimal access work, where you don't need to expose a large amount of the spine, and just minimal access portals can help you place implants into the spine with good accuracy and helps conduct minimal access surgery well. You also have some other technology advances in the field, and there are some other options which are like conventional CT scanners, which can be used in the OR. So these are, for example, the Airo and the BodyTom by Samsung. They are considerably more bulky than the OARM, and they have less mobility, but they practically are like keeping a CT scanner in your OR. And your table has to be special, which moves in and out of this CT scanner, but predominantly the CT scanner or the Airo or the BodyTom stays fixed in one OR, and the table moves in and out with the patient. The advantage of the OARM is the OARM sometimes can be moved from one OT to another if you have multiple navigation systems. So with the intraoperative CT scanner, I think you get better soft tissue details. You can have larger fields of scan as opposed to the OARM. So those are some of the advantages. Obviously, cost of the intraoperative CT-based navigation system can be more than can be pretty high. So this is in quick comparison. the different generations or the evolution of navigation systems. So the first generation had preoperative CT. You had to manually register and match multiple points to be able to get implant accuracy accurately placed in one segment. And it was not compatible with minimal access surgery because you need to match multiple levels. And the problem was there was loss of fidelity if there was minimal movement. And then the entire process of matching, registration, and verification had to be repeated. The image acquisition was not intraop, so you had preoperative CT and the patient position was prone inside the OR, so matching was not possible. To exclude matching or to give up on matching was not possible. The image quality was good considering you have done a preoperative CT. How it changed in fluoroscopy 2D was that you had intraoperative image acquisition. So the registration was quite often automatic, but the drawbacks were that the image quality was that of a fluoroscope and not truly like a CT scan. This was improved upon with the 3D fluoroscopy, where you get cone beam technology and you use the Shyam but get multiple shoots done, and so the reformatted images look like CT scans. And then eventually now what you're looking at are like intraoperative CT scanners like the OAM and the IRO and the BodyTom, which can function as intraoperative CT scanners and help you with real-time images intraoperatively and help you guide implant placements accurately during your surgery. So that concludes today's talk. So I thank you for a patient listening. This was a brief session on the introduction to navigation technology and the evolution of navigation systems since their inception to currently third generation navigation systems such as the OAM, which are currently in use. Thank you.